you. All right. Let's talk a little bit about skin cancer. So let's see if you guys remember, we talked about this in assessment, which is which, basal or squame? There's two pictures up here. You guys remember what the distinguishing factor is?
Circle.
They're both kind of circular.
Shape.
Look at the borders. One has kind of a scaly appearance. One has more of a pearly white border. Which is which? You guys remember? Squame is usually scaly. Basal cell usually has a pearly white border. Where are the most common spots you're going to see skin cancer? Your face, right? Ears. In this rural area, we have a lot of farmers, right? So people's ears, because farmers don't really do a lot of great prevention, I would say, in general. And they think, well, my face is covered because I wear a hat. Well, they might wear a baseball hat, which covers part of their face, but they have a lot of exposure to their ears, right? So the ears, the forehead, the cheeks, especially if they wear sunglasses where it reflects off, can be areas that are pretty prone to developing skin cancer. People's hands, like the top of their hands if they work outside a lot, can be areas, or really anywhere that has a lot of sun exposure. Okay, so start screening young. Skin is the most fragile organ. It's obviously damaged by UV radiation, chemicals within the environment. This is not new for you. So it's usually classified as melanoma or non-melanoma. So if somebody has a basal cell or a squamous cell, that'd be a non-melanoma skin cancer. And then there's obviously melanoma, which is a lot more aggressive, a lot worse form of skin cancer. So it arises from melanocytes. So these are just cells that you have on your skin. Melanin, which makes up the color of your skin. If you're darker complected, you have more melanin than if you're lighter complected. You don't need to know these different nevi, but these are, if some people have these, you're actually more prone to developing a melanoma. So people who have a lot of moles, are born with a lot of nevi, have these large skin spots, it puts them at more risk for developing a melanoma later on in life. So different types we'll talk about. So melanoma will spread, it can either spread superficial, so on the surface, which is how your non-melanomas spread, or it can start to spread deep into the tissue, which is why it makes it way more aggressive, where your basal and squamous cells just kind of sit on the surface and they can spread in the area they're at, but they usually don't invade like the bloodstream, they don't invade organs, where melanoma can spread through like the lymphatic system or through the blood system. Here's some statistics. Okay, so which is which on these pictures? Basal or squame? What is this one? Squame. It's scaly, it's kind of raised, right? This is basal, it has kind of that pearly white appearance, so that's how you can tell the difference. Again, those develop kind of anywhere on the face, the skin. They can spread kind of superficial. A lot of times you'll see on like people's noses, they will have to have these like surgically removed. 8 out of 10 skin cancers are basal cells, so that's probably the more common, but there's a lot of squame as well. So actinic keratosis, this is an epidermal skin lesion that is people get from chronic sun exposure. So you'll see this sometimes in elderly, where they get kind of these blotchy whitish red patches on their head, their scalp. They can get them on their cheeks. So any area really that's had a lot of, sun exposure, they'll get kind of these rough patches on there, sometimes scaly. And if they tend to pick at them, they'll bleed very, very easily. So this is not something that's going to harm them, but could potentially be a precursor that could lead into a basal cell or squamous cell, so called actinic keratosis. So the leading cause of skin cancer is sun exposure, right? Or people who like to bathe, sunbathe, tan. Tanning beds has a very high incidence of relating to melanomas. When I was leaving Omaha, there was a group of people who worked really closely with the American Cancer Society, and they were doing a campaign called The Bed is Dead, where they were going around to high school students to try to get them to sign a petition that they would agree not to use a tanning bed for a year, and if they didn't, they received some sort of compensation. It wasn't a large amount of money, but they were trying to start a movement to prevent these young girls from developing melanoma. Because it used to be, if you were diagnosed with a melanoma that had invaded deep enough into the skin, it was very life-threatening. It was a very aggressive form of skin cancer. A lot of young people were dying of melanoma, and there wasn't a lot we could do for it because it's not a cancer that responds very well to chemotherapy. We'll talk about that in a second. So, some major risk factors: light-colored eyes, light-colored skin, having one blistering sunburn at some point in your life. So how many of you have had a blistering sunburn? Many of you. So you're all at risk to develop melanoma. Frequent sun exposure, frequent people who tan and don't use sunscreen, or people who have a lot of moles in general can be a precursor. If you have anyone in your family with a history, there is a small genetic component. And then non-melanoma is just environmental factors, again, the sun and lots of sun exposure. Not the most, but a lot of women will get melanomas on their lower leg area, like their calf area is a pretty common spot for melanoma for whatever reason. And if you think about it, sometimes if they tan a lot or lay out in the sun, it's probably an area with direct sunlight to their shins. The eyes, there is a very high incidence of melanoma to the eyes. So if they don't wear sunglasses, they can actually get it in their eye. It can be very damaging. But really can occur at any spot on the body. So again, risk factors: single blistering sunburn during childhood, more than doubles the risk for developing melanoma. Geographic or environmental. So obviously if you live in sunny California and you have 300 days of sun a year versus we live in South Dakota and we might have 65 days of sun a year, right, or full-on sun. But also UV rays. So even though it's not always sunny, you can still get UV rays and still put you at risk. If they have actinic keratosis, so again, those sunspots that become bleed when picked at, light-skinned people. It is pretty rare in dark-skinned people because they have more melanin and they just don't have that risk of the damage to their skin cells. So how do we prevent it? Don't use tanning beds, use sunscreen. What SPF should we use? At least 15 or higher. I have told you guys this before. 100% or 100 SPF is literally a marketing campaign. 100% or 100 proof SPF is just as good as really anything over 15 or 30. It's just you don't have to apply it quite as frequently. It lasts a little bit longer, but truly anything over 15 or higher is enough. To even wear broad rimmed hats so that their ears are covered and the full face is covered, sunglasses, head to toe skin exams. They're teaching cosmetologists now when they go to hair school to look for moles in people's head, because a lot of times your head gets a lot of sun exposure, right? And you don't always think about it. It's not like we lather sunscreen on our head, especially if you have hair, but a lot of people have moles on their head, and that can be a spot that melanoma can creep in. Also, underneath nails is a common spot, so nail technicians are also trained to look for melanoma or irregular looking skin areas when they're doing nails. So really anyone that's going to be in contact with somebody's skin is being trained to screen for these things so we can prevent it earlier. So some clinical manifestations. Obviously if a mole changes color, the surface changes, size and location, which we'll talk about in a little bit. Promote early detection. So if they have a non-melanoma, usually they're just gonna remove the malignant tissue. So sometimes that's done right in the dermatologist's office. They literally will just scrape that bit of skin off, send it to pathology, say, yeah, you had a basal cell or you had a squamous cell, and monitor that it doesn't come back or spread somewhere else. Again, those are not usually ones that will invade like organs or other tissue. So if somebody is diagnosed with a melanoma, early identification is key before it does start to spread. So if you had, let's say you had an abnormal looking mole on your back and you went into dermatology and they said, yeah, I think we should remove it, and they called you and said it was positive for melanoma, they're probably gonna have you go back in and do a deeper excision of that area, because melanoma can spread deep into tissue pretty quickly. So they will go and usually do a wide excision, so go a little deeper and a little wider, just to make sure there's no other cells around there that have melanoma in there. They'll also do like lymph node sampling depending on where it's at. So if people have melanoma on their legs, sometimes they'll take lymph nodes from their groin or near the site to see, is there any spread to the lymphatic system. They will also draw just a regular set of labs to see, are their liver enzymes elevated, because it can metastasize to the liver. They can do a PET scan to see, has it spread to any other organ. So melanomas can spread. I've seen it in people's lungs, in their liver, in the brain before. I took care of a lady who was in her 40s. She was an elementary teacher and had a massive seizure while she was teaching. They took her into the ED, scanned her brain. She had a huge tumor. They went to remove it, and it was actually melanoma that was in her brain. So it had spread and grown, and they never found any lesions on her skin. So they think maybe she had a small mole at some point that became necrotic, fell off, and then that melanoma probably was latent or just kind of laid quiet in her body for some time. Maybe stress, maybe a poor immune system. Something happened that it started to mutate and it spread into her brain. So she had it surgically removed and actually lived for a very long time, surprisingly. So it's staged a little bit different. There used to be only a 25% chance of survival within 5 years if it had already spread. So if somebody had stage 4 melanoma, the prognosis was very, very poor. So they use this kind of level of staging. So if it's only on the outer layer of skin, it's a stage 0. If a tumor is formed, but it hasn't spread, it's stage 1. And then if it goes deeper and deeper, and then obviously stage 4 is if it's spread to some other site in the body. So to an organ, to the bones, to lymph nodes, then they have stage 4. So they use the ABCD rule. You guys, we talked about this in a health assessment. We'll see if you remember. So asymmetry, so if you have a mole, does it look symmetrical? So are both sides equal? And you guys should be doing regular skin checks on yourselves, especially if you've had a lot of sun exposure, and this is what you should be looking for. So if you have moles, do both sides look fairly similar? If you drew a line down the middle, do the sides match up? Or is one side pretty irregular and doesn't look very symmetric? How about the borders? Can you draw a circle or oval around a mole? Does it have pretty decent borders, or are they kind of erratic? That is a sign that it could be something more than just a mole. The color, so if there's variation, most melanomas tend to be brown or black in color, but they are finding that there's some that are white, there's some that are more reddish, or might have different colors. So if there's a color variation, that potentially could be something abnormal. And then the diameter, so if the diameter is more than 6 millimeters, or like the end of a pencil eraser, so bigger than just a standard pencil eraser, that's about 6 millimeters in diameter. So if it's larger than that, that potentially is abnormal and could be a risk that is something more. You need to get checked at. And has it changed, or is it evolving? So They use the ABCD rule, and then they've added an E in there. That means evolving. So if you have a mole that you noticed this fall, and now it's 2 months later, and that has doubled in size, that should be concerning. You should get yourself an appointment with dermatology sooner than later, because that probably needs to be taken off, okay? So if it's evolving over time, now if you had a mole that has been there since you were 6 years old and it hasn't changed in color and size or in borders, then it's probably fine. Okay? So how do they diagnose it? They'll literally take off that mole or lesion, send it to pathology, look and see if there's any melanoma cells in there. They test for metastasis, so they might do CT scans or a PET scan, do further staging. They'll draw labs for liver function, so LFTs to see, okay, is it spread somewhere? They will do an MRI of the brain because it is a cancer that can metastasize to the brain. They'll check a regular CBC, sometimes do a chest x-ray to look for any nodules in the lungs, another primary spot it likes to go to, the bones, and then they do microstaging. So that's where they do the wide excision or deep excision. So they're going in and taking deeper areas of tissue to make sure that they got all of the melanoma removed, because it can be a very aggressive cancer. So wide excision, again, so if you had a small mole on your arm, they would go in and take quite a bit of skin around that to make sure there's no cancer cells in that extra area. Full thickness is deep, going deeper for that same reason. They can do a lymph node dissection, so then they're at risk for what? Lymphedema, right? So it's usually used for staging, but sometimes they can do it for palliative management. So if somebody has a large melanoma sitting on their spine or in their brain, obviously you have to do surgery and get rid of that, or it will cause them more complications. So treatment, it used to be you got melanoma stage 4, you better get your affairs in order because you had a very short period of time to live. Now, with immunotherapy and targeted therapies, people are living 10, 20 years with stage 4 melanoma, which is pretty unreal. When I first started working as a cancer nurse, you would see a lot of young people dying of melanoma. It was very, very sad. 20-year-olds, 30-year-olds, 40-year-olds with the young little kids because they loved the tanning bed, they loved to sunbathe, they grew up in a time when sunscreen wasn't beat into their heads, right, to lather kids up. That used to not be a thing. And chemotherapy really didn't do anything for melanoma. It doesn't really treat it. It's kind of resistant to chemo. So you'd make these people really sick and their disease would continue to spread. Now they have immunotherapy, they have some gene therapy, they have a lot of targeted therapies. So people are living a lot longer. They usually don't use radiation unless it's for palliative care. So unless they had melanoma sitting on a bone that was causing a lot of bone pain or numbness and tingling to that area, because they have to use a very high dose of radiation to be effective. So melanoma is kind of a tricky little cell that's very, very aggressive and very resistant to most normal treatments. So key note there, use your sunscreen and don't use a tanning bed, for those of you that like to tan. So assess, document lesions, educate patients to get yearly skin screenings, especially if they have any of those risk factors. Do a thorough skin assessment on yourself and encourage others to get a skin assessment. Don't tan, inspect and help with the skin, measure and record skin lesions, and an annual dermatologist appointment. And that is skin cancer. Okay. Yeah, threw that pretty down. So what we're gonna do is we're gonna talk about anemias.